My name is Dumim Simang, and this is our fifth Pulse of Practice webinar series. And these are online series that we have monthly on the first Monday of each and every month. The invite is for everyone: clinical associates, students, employers, employees, people that want to know more about the program, academics, maybe just anyone that's interested in the clinical associate program or wants to learn more. But the main aim of these sessions are to empower our students to be aware of the diversity of the workplace for ClinAs, to help students have questions, answers that they really want to know, and really importantly, to link graduates to students and students to graduates through this community. So we're hoping that by doing this, we're forming a little bit of a community of practice where students and graduates and even mentors, even people of other cadres can join or can make connections or linkages through this community. So, a little bit about myself. I graduated from the University of Pretoria and I started working as a Clin A in 2013. So, I've been working as a clinical associate for over a decade now. And over this decade, my career path has taken very many different directions and avenues, which I won't go into today. But if you mention it, I've probably done it. My interests have a very deep interest in medical education, family medicine, primarily in the private space, and healthcare management, and that's where my postgraduate studies are kind of focused into. So, my aim here today is to help strengthen clinical associates, student professional identities. Like I said, build community of practice through connecting clinical associates to students and students to clinical associates. And with the hope that in sharing our experiences, we can learn more, and we can help students really build a path to where they want to be, or build a path to excelling as clinical associates. So today we have three guests. Each of them will be speaking for 10 to 15 minutes. If you have any questions, please feel free to post your questions in the chat, or you can just raise your hand at the end of the session. We will be having a question and answer session right at the end after the last speaker have spoken. Um, if you are a student and you've got a question, please post your year of study and the university so that we know where, we appreciate the student involvement and we want to see where our students are coming from, where the questions are coming from. I'm going to start then with our first speaker, whose name is Tshegofatso Mpolokeng. She's from Mafikeng, graduated in 2011 from Wits University, and is currently working in the Northern Cape at the Aurum Institute. So a very warm welcome to Tshego.
Good evening, everyone. So unfortunately, my laptop is in for IT, so I'm using my phone. So using a camera would be a bit tricky. But otherwise, as Tumi has said, my name is Tshegofatso Mpolokeng. I am originally from Mafikeng in the Northwest. Um, I was in the first group adverts, the first BCMP group adverts. This was in 2009 when we started the program. And I had not applied for the program. I think all of us in the group, we didn't apply, we were selected. But mostly because we had applied for, okay, let me speak for me personally. I had applied for medicine and nursing, and then the university, my marks didn't qualify for medicine. So we had this special doctor that started the program, Dr. Truscott. He was the one who called and told us about the program. He was very convincing. But then the other reason that I think mostly that weighed in on my decision was that the program was funded. So it was less problems on my side. Then, yes, it was a very challenging 3 years, But I guess because we were a small group, we faced it as a family, if I would say that. Um, but it was very challenging, but we learned a lot. I think in those 3 years, what encouraged us more was that our lecturers always encourage us to say that you must take the lead. This program is in your hand. Your profession basically is in your hands. So you must learn so that you can advance yourself. And at that point, we needed to prove ourselves because people didn't know who we were. Everywhere you go, every room you enter, you need to explain what is BCMP, what are we clinical associate. It was very frustrating, but yeah, that was that. We graduated in 2011. I started working at Lehoroti Zerust Hospital Complex, also in the Northwest, where my bursary came from. So they had selected each and every one of us from different districts. We were placed at different hospitals. So with us, you were just placed and you learn as you go. You're assigned to an MO. You just had to work and prove your clinical skills, your clinical management, and then as you work, the MO you're working with eventually will trust you and you gain independence. I think also the challenge with us at the beginning was that all our scripts, everything that you wrote on the patient file, on the prescriptions, everything had to be co-signed by your supervising MO. It was a bit challenging, especially after you've gained your independence and can manage patients on your own. But yeah, we worked through that. And then I resigned in the government hospital. And then I started working in the Oram Institute, and that's when I got into the NGOs. I started at the prevention department in the MMC, where I was the lead team leader of the group, also conducting the actual surgical procedure. From there, I guess that's where I got into leadership, and then from there I changed the program, went into care and treatment. I was running the ARV clinic at the hospitals. After that, we were supporting the clinics with advanced clinical care for the HIV program, alongside with the TB program. Um, yes, from there in 2022, I got retrenched. That's the downside about working in the NGOs, because it is funded. So anytime there are budget cuts, so retrenchments may hit you or may skip you. I got retrenched in 2022. I started working, and then 2023, I worked for the Wits RHI. I was a clinician at the clinic, also helping run the ARV program. And then this year, in May, a month ago, I started with the Oram again. Now I'm the DRTB, drug resistant TB coordinator with the Oram Institute. We're supporting the DOH with the management of DRTB patients. So, well, in this journey, okay, before that, my interest, and I forgot to mention, mostly in HIV management and quality care, especially for the pediatrics. So that's where I got my interest from when I got into the ARV and care treatment. That's where my passion for the pediatric HIV management came from. So in the NGO world, there's no, how can I put it? It's also, like I was saying in the beginning, that you create like the path that you take, like in leadership or the roles, it's all dependent on you, how you prove yourself and how you best manage your things. And also with because I also did HIV after the BCMP, I did the honors in HIV management. I did a few courses for project management, so that made me advance a little bit more. And also showing interest in certain things, it helps. So yeah, I guess that's it with my journey for being in the clinical associate program.
Thank you so much, Sephora. But that's a very interesting area or more speciality, if you can say so, inverted commas, that you're in, or facilitating the treatment of drug-resistant TB. So very, very interesting. I'm sure we'll have some good questions.
Thank you very much.
Okay, so next I'm gonna ask. So my next speaker is Dimakatso Nyonyana. She's a clinical associate. She graduated from the University of Wits in 2012, and started at Bertha District Hospital in 2013. After that, she joined the Community Orientated Substance Use Program, COSUP, in 2016. Initially providing clinical services, now she leads COSUP's capability and training component. So she manages the training on drug, substance use, and harm resistance for the COSUP unit at the University of Pretoria. She's developed and led national workshops on harm reduction and co-authored an article on advancement in this field. This is actually a very interesting field, and I was actually speaking to my first years about this. So I'm very happy to have you on the call and to have some first years on the call as well, so they can hear more about your work in this space. Dimakatso is very passionate about people-centered care, advocates for quality, person-centeredness, and person-centered approaches to community health. So please give a warm welcome to Dimakatso. The floor is yours.
Thank you to me, and thank you to everyone. Good evening. Simple thank you to you also as my predecessor. It's strange because the stories are so aligned. I think with the first cohorts, studied in Wits, 2010, got a phone call actually on the 1st of January saying, hey, there's a program, it's fully funded, you're starting on the 3rd. So everything was just, bungee jumping experience. A lot of unanswered questions, but also thrilling because you're getting this opportunity. At the time, not really understanding what it meant, but as Sivu said, fully funded and you get a stipend. At that time, that was such a whoo and an exciting experience. Did it for 3 years, faced exactly some of the challenges she mentioned. I think it might have been a bit easier for us in one component, in the sense that people sort of had an idea what a clinical associate was. But also trickier because of that, they could even ask us even more questions around, why don't you just do medicine? Is this even sufficient? What are you doing? At the time, very impressionable. That question weighed heavily in us questioning, what is this? What is the importance of this? Especially because at the time, got this opportunity because I also applied for medicine, and this became sort of, I was settling. Now, within the 3rd year of it, it was, okay, now we are graduating, you're finding independence, you're getting to define what clinical associate is for myself, instead of the generic mid-level healthcare worker, what it means for me to be a clinical associate. After graduating, there was a 4-month period where we didn't get jobs as promised. As I think anyone can understand, it was such a confusing time because there's a way for us to sort of accept that we are in this path and get to appreciate it. One of the key elements was the fact that, at least we have a job guaranteed. But that 4 months was such confusing and troublesome because, not knowing what your next steps are and what must happen now. And we did the whole, we're gonna approach the government and everything else. Ultimately, we got the call that placed me in Bethel Hospital, which is Germiston. Now, I'm from Pretoria, born and bred, South. And if you've been in Pretoria and you've been to Germiston, you understand the contrast between the two areas. But alongside my fellow clinical associates, Zenanda and Ndlwane, we served in internal medicine for 3 to 4 years at the time. And then I had the opportunity to join a new program, which was a program at the time. We didn't even have the name COSUP, the Community Oriented Substance Use Program. We just knew that it was a program geared at providing healthcare service to people who use substances, specifically those with a chaotic pattern of use. This led to, starting a program from scratch, what the name is, how it looks like. And this is when elements of what happened in my BCMP years played out, and it served me back because in areas or platforms where they were not preset or pre-structured for me, I got to be innovative in those spaces. What the forms look like, what type of services would we do in collaboration with multidisciplinary team, but we got to design it. I was not anxious anymore. I was more thrilled because I was experienced in entering areas that were not preset, and you get to develop. So in the first 3 years, there was the experience, and once it sort of plateaued for me, it was very clear this is what I do. Then I was able to say, I need more of a challenge. What else needs to be drawn and designed? And this is when a lot of my energy right now goes into training, specifically training community-based organizations to look at the plight and experiences of people who use drugs. How can they ensure that they offer services to people who use drugs, address issues around various two services for this marginalized population or community, and how do we optimize their health within their specific settings and specific challenges, looking at issues of homelessness, also which is highly associated with issues related to substance use, and other elements in terms of how do you get an individual to optimize their lives at a biopsychosocial element. Before even doing BCMP, I always known that I wanted to work with communities. The BCMP program honestly afforded me a chance where I could experience that. Now at hospital, you're at the end of a lot of people's, especially at internal medicine, you're sort of in the middle to end of their condition. You're not doing primary health care. But also that experience afforded me so much knowledge. With all of its challenges, especially, having to work with other people at the team, some nurses feeling that you don't belong here, or what power role you're supposed to play, and some medical practitioners feeling like you're a threat, but also getting the opposite, getting people to support you and teach you and help you grow in your profession, and people who pull you up and always give you an opportunity to experience more. All of those experiences completely 100% equip me for what I do now in terms of how do I, at every junction, with every client, and now specifically with every organization, how do I get them or empower them and give them what I had received? And how do you best serve people who are marginalized and who don't get to receive service as general population? How do you address issues of barriers from stigma that we give to individuals who use drugs to structural stigmas that we didn't even understand or realize? And how do we break those chains to ultimately ensure that every individual gets optimized health and quality of health, which I truly believe everyone deserves. So yeah, you may know there's not 10 minutes, but that's the gist of my experience as a clinical associate. Thanks.
Thanks, Dee. I think the work that you're doing is so important, and I don't think a lot of people understand the work that you and as COSUP or as part of COSUP does, and how important it is in our communities. And your initiative or this initiative is just really important, and it's changing lives within our community, within our communities rather. So yeah, you're doing great work. You're really doing great work. Okay, so our last and final speaker then today is Danelle Netman, who graduated from WITS in 2015 and worked at Get Health Clinic in 2016, followed by the Cardiovascular Risk Institute. She then moved over to ER Consulting in 2018 and became a manager until 2022, and then she moved and joined us at UCT. Okay, Danelle, your turn. The floor is yours.
Hi everybody. Okay, so as most of you actually may know me, my name is Danelle. I work in the Division of Clinical Associates at WITS University. I've come quite a long way to get to this point, which I'm quite excited about. And I'm quite excited to share my journey with you so that you may know where I actually come from and what I've actually done. Apologies if you do hear my baby crying in the background. His father's taking care of him, so you must know. Okay, so we're going to talk today. I'm just going to give you an introduction as to what I've done or what I am doing, as well as just a brief idea of what the role of clinical associates are within the emergency medicine space, and then just a few personal achievements, and then basically what the path is going forward into the field of emergency medicine. Okay. Okay, so basically I am a full-time mom to a 7-month-old baby. He is my the newest and only addition to my family, as well as an associate lecturer at the Division of Clinical Associates at WITS University. And I am what most people refer to me as a professional student. I think it's because I've studied since the day I left high school. So most people do refer me as a professional student. You probably understand why if you know me personally. Okay, so just a path or just letting you know where I've been and what I'm doing so far. So I used to actually be a clinical associate and manager at the Get Health Clinic, and this was in 2016. So I graduated from WITS in 2015. I was then a key accounts manager and a clinical associate at the Cardio Group, as well as the Cardiovascular Risk Institute. And this was from 2016 to 2018. This was a very interesting job for me because I did clinical work and I also did administrative slash managerial type of work. And why it was really interesting is because I realized then and there, between the period of 2016 and 2018, that corporate was definitely not for me. Just like how most people may actually come to the realization that the clinical space is not for them. I think I've come to the realization that I could never work in a corporate environment unless there was an element of education or a clinical aspect to it. So at Cardio Group, and I do hope many of you are taking some of these names of the companies that we are all discussing in these webinars, because they do, I'm sure, offer quite a lot of employment as the years go by. And by the time you graduate, you can look these companies up. And I know for a fact that Cardio Group hires clinical associates. My colleague and I were the first to be employed by them, and since then they have employed quite a few. So my job at Cardio Group was related to, it was a startup company, and it was related to creating a medical app and integrating that with devices, as well as integrating the system that was then complete with a medical group such as ER24. So ER24 is an ambulance service. And what this company did was actually we utilized a few medical algorithms like Framingham as one of them, and it was related to cardiovascular disease. So we utilized that, and I worked very closely with an IT professional, and we put that into an app that also uses blood pressure and glucose monitoring. And if the patient does have a high risk of cardiovascular disease, or if they had maybe very dangerous levels in terms of their blood pressures and their glucose levels, it would automatically the system would automatically speak to the ambulance service, and this could help the patient. So if anybody was having an emergency situation as a diabetic or hypertensive patient, whether it was, severe hypoglycemia or whether the patient was developing features of stroke, this system would actually allow for them to immediately be treated and, get some assistance. So that was quite interesting. And then the Cardiovascular Risk Institute, that was owned by a cardiologist who also owned Cardio Group and was my boss, he actually let me work in his practice because he knew how passionate I was about patients and how much I actually loved working in the clinical space. So I actually I worked very closely with him, and we worked with quite a number of delegates from other countries, and like kings and judges and Nelson Mandela, I think, was there at one point. It was quite a lovely place to work at, but I kind of needed more than that. So that's when I moved to the company called ER Consulting. I have to please make sure that you guys understand this is not ER24, so it's not an ambulance service. ER Consulting is a medical management company that runs emergency departments all around South Africa. So it is national. And I worked there as the first clinical associate in private in emergency medicine. And then I became manager for all the CAs around South Africa that were working within that emergency medicine space. That was the best time of my entire life. And I can say that because that is where my future was shaped in the space of emergency medicine. ER Consulting is, and I know, and I think many of the students and my colleagues will know that even though I don't work there, but I still speak highly of them because that is the place where clinical associates were allowed to flourish and grow and develop their skills so freely while being supervised. And why I love this place is because that supervision, which is very strict, is actually the reason why I know what I know in emergency medicine, or why I'm able to actually perform specific emergency skills or even feel comfortable to work in the ED. It is because of them. So they actually allowed for me to grow quite a lot. They paid for my studies, the honors in emergency medicine. They paid for part of my master's in emergency medicine. So great company to look at. And I hope, even if some of you, and I will give you this advice even at this stage of this presentation, that even if you are not planning on staying in the space of emergency medicine, I hope that every one of you try and actually pass through this company and go and then find your path. Many of us think that we do our electives or we do our rotations, and we love surgery because one person allowed us to do certain things, or it was just a good rotation. But that doesn't really give you a true understanding of that profession. And I feel like once many people who feel that acute medicine is scary actually go into the ED and work, you end up loving it so much, because the satisfaction of saving someone's life is something that I can never explain to you. You would have to experience it for yourself. It literally changes you, and I know for a fact it's changed many people's perception about what they actually wanted to do in life after saving someone's life. I mean, it's addictive. And now I work as an associate lecturer at the University of Witwatersrand, and the reason for moving out of ER Consulting is because, again, I needed more. And one of the most important things that someone actually told me at ER Consulting is that you should never be the big fish in the pond. And that's something I try to tell everyone. I'm not trying to blow my own horn or anything, but I got to the point where I was actually teaching the doctors that would come into the ED. And then I realized I'm never learning from this. So I needed to leave, and coming to the university is allowing for me to expand in my studies and expand in the field of education, which I completely love. and it's something I used to do as a manager. I would do all of the training for all the clinical associates and for the doctors, and as well as the orientation within the company. So I realized that's something I wanted to expand on. So in terms of my studies, I'm just going to pick a few. Like I said, I've studied since I've finished matric, which is a lot longer than what's shown on the slides. But basically, the major aspects of my career that revolve around medicine is nursing. That I first got a diploma in nursing, and then I've got a degree in nursing at UWC, which is in Cape Town. And then I moved in 2013 to Wits to study BCMP and graduated in 2015. You know, when it came to my final year of BCMP, and I know many of you, if you are third years that are on here, or if you're first or second years going into third year, as hard as it is, I need you to please understand that this is the time of your life where you secure jobs. And I worked like someone was watching me. And you can ask your colleagues that have graduated. That is something I've always told them. Work as if someone's watching you, because someone did watch me, and I don't, to this day, I don't know who, but I was recommended by someone that I worked with at Tambo Memorial, and I got offered a job even before I wrote my final exams. So that was such a blessing. And you know, my colleagues couldn't understand. And I know that many people have challenges in terms of finding work and employment. But I think that when you also apply yourself and you put your best foot forward always, someone is going to find you, and someone is going to offer you something, or someone is going to see the value in you. And I think that you need to understand this. You also need to understand that when you are training with people that are also growing just as you are. And sometimes they may take a path that allows them to grow exponentially and a lot faster. And then they look back and they're like, oh, wait a minute. I used to work with this clinical associate Danelle. She was excellent. And you know what? I think she's perfect fit for this particular thing. And then they reach out to you, and then, you know, or you go for an interview and you see this person you used to work with, and they actually vouch for you in that interview. So please make sure that that is something you always remember, because that is something I did, and I landed my first job. And then, yeah, then even when I went to ER consulting, it is actually the same thing. I didn't actually apply. So while I was there at ERC, they paid for the honors in emergency medicine, which I did in 2019 to 2021. It was such a blessing to do it there, because I got to practically you know, learn everything that I needed for the honors program in my actual job, as well as in the clinical hours at the government hospital. So it was lovely. It was 24 hours a day, 7 days a week, emergency medicine. So yeah, I loved it. In 2022, I actually got into the Masters in Emergency Medicine program, specializing in clinical emergency medicine. I'm still doing it, but I am doing my final module. So I am going to definitely graduate next year because I have to complete my research, which ends next year. So yeah, I'm quite excited about that. And then next year, I hope to apply for my PhD, either in emergency medicine or in one of my other fields of study within emergency medicine, which I'll speak about. Okay, so just very quickly, in terms of the role of clinical associates in emergency medicine, this is basically what I did at ER Consulting. You clerk patients, you initiate the consult, do necessary general exams, physical exams, you order the relevant investigations, and then you decide on the disposition for this patient and formulate the management plan, which is whether you're admitting or discharging the patient. Be mindful that as you grow within the space, your supervision does become a little less, because now you have gained some independence within that field, even though you are being supervised and countersigned. It is also important to note that in private, it's not like government. Private, when there are you know, plans, and there are like policies that are negotiated between private hospitals as well as these emergency medicine departments. And there is that impression or understanding that doctors will see the patients, especially in private. So when we get countersigned, that there is the notion that your patient is being seen by both the clinical associate and the doctor, which definitely occurs, and it is the case. However, there are instances where we are the only person the patient sees, mainly because it is it may be a busy department or a busy unit. However, the doctors you work with and you've created a you've created a good relationship, they'll be able to trust you because they actually know what you're capable of doing. It was also a little bit tricky towards the end, which again motivated me to leave, where the person that I was teaching was actually countersigning my work. And I didn't find that to be it was strange for all of us. And I didn't feel like I was being protected, which is something that I think people within our degree needs to kind of understand that not having a counter signature doesn't mean, okay, I've gained my independence and, that's the end of it. So I think people need to understand the importance of doing it. It actually forms part of the protection. So I think please don't dismiss it or think that it is something that is unnecessary or negative. It's actually a good thing for you. Yeah, so we also performed necessary life-saving and non-life-saving interventions in ED, one of which I assisted the trauma surgeon to do actually did 3 of them, a front door thoracotomy, where we actually opened the patient's chest in the ED while he was alive, and we clamped the aorta and we stopped him from bleeding, and some made it, some didn't. But that was an amazing procedure, and I got to do it because I was senior on the floor and also because I was always there. So the trauma surgeon was like, listen, it's time. So those are the kind of things that we can get exposed to and that you can actually do. So we also responded to code blues in ICU. You either go as a team or you go alone. I did do many of those. It's always scary at first to be the only emergency medicine person that's consulting in ICU and running the resource on your own. However, it is something that really builds you as a person. So scary, but also it boosts your confidence quite nicely. We also did consultations and documentation of WCA patients. These are workman compensation patients. And we would write referrals and also provide motivational letters for our patients. So generally, whoever sees the patient is the one that has to write it because you have examined the patient, taken note of the injuries, you've done the exams, you've done everything. So we would do them for our own patients. And then in terms of administration in the ED, or in the emergency medicine space, you can either be the head of your team or you can be a head of a unit. So my colleague, actually, when I left, one of my colleagues had the great opportunity, and I think she's still in it, to actually be the head of one of the emergency departments in Johannesburg. So she's actually running it, and many people don't really know that she's the clinical associate, which is a little bit sad, but she performs really well, and she does obviously introduce herself. And when they do find out, oh, you're a clinical associate, and it's quite a proud moment and a proud thing to actually be part of. So I'm extremely proud that she's gone to that level, and this is something that shows that there are doors that are opening and there are opportunities for us to grow within the space. Personal achievements, one of the things that I would always consider as a personal achievement was being promoted to a manager very early. It's very difficult to get into the managerial space, and I was very blessed to have gotten that opportunity early, which boosted my career quite a bit. It allowed and opened quite a number of doors for me. Not all the doors I entered, but that really did help. So I would always encourage everyone to try and take up a position in a managerial position, even if it's not full time or just gain some experience. So then I was also another achievement that I consider is the ability to be part of courses that traditionally were only considered for doctors, like ultrasound courses, advanced trauma, international trauma, and then also ACLS for experienced providers. These were courses that traditionally were not allowed, but through ER Consulting, and because they offered the courses, I was actually allowed to do all of them, which allowed for me to actually get into the MPhil program, which again is definitely an achievement. So that program for me, I felt was a big achievement because there were only 16 of us in my class. They only take 16 a year. And out of the 16, only 6 of us were actually South Africans. And out of the 16 of us, there's only probably 2 of us in my class at the moment. So yeah, that was quite an achievement, and I'm definitely finishing. I am the first one to do the MPhil in emergency medicine at UCT. I was the only one until this year because I'm now exiting, they've now taken a second clinical associate. But unfortunately, I'm not quite sure why, but she had to leave. So I'm back to be the only one. So please work hard and get into this program. It's Very, very good. One other achievement was being selected to represent emergency medicine in the COVID-19 pandemic. We worked nationally, so we worked at the hot zones, if I can call it that, in ICU, and we were actually meant to be replacing the specialist physicians that were not available because there were so few of them and there were so many patients. They wanted clinical associates to form part of the specialist team, so we worked in the ICU. There were also not enough nurses, so we were luckily experienced enough to actually take over ventilated patients. And one of the really cool thing is I actually got an opportunity to do dialysis for patients. So you were learning on the job. Like the dialysis nurse will come and you'll be like, listen, here's the machine, here's the solutions that you need. These are and it's all related to electrolytes. So here's the solution here. This is how you connect the patient. This is how you connect the port. We had to do that, even replacing the port. So very, very cool experience, very sad and depressing, but it was amazing. So some of the things for career path in emergency medicine. The first one, I'm the first one to complete the MPhil, so there's not many things that not many doors that I've opened as yet, but I know there are a few that have been opened, specifically in emergency medicine. Then there's the clinical route, and this clinical route is where you can work full-time in the clinical space in a place like ER Consulting. There's an academic route, which is the clinical aspect, and that's where you can teach the clinical aspect of emergency medicine. And the MPhil actually allows me to do that because some of my specialities, even though it's clinical emergency medicine, but it does have disaster medicine, health systems, and critical care. So I can do all of them as well as research. Then you can go the full academic route in terms of research. And then internationally, you can actually work at other universities or work in administrative positions like clinic managers, etc. So I know that there is a little bit of an issue with clinical associates working overseas, but it's not just us. It's actually an international or a global thing where there's no board exams as yet to actually work in other countries for them to either come here or for us to go there. But it is changing, and in Canada and US. So between those countries, you can actually work in either wherever you want. So yeah. So in terms of words of encouragement, what I will say is never listen to the negativity of other people. Never think that what another person's path that is a negative path is going to be your negative path. I have never had an experience that was bad while being a clinical associate, which is why I'm still in it. There's been opportunities for me to go into camp, and it's not something I choose to do. But I'd rather choose to be an amazing clinical associate and actually specialize in the field. So for me, I would always suggest that is something you consider. Make your own path, be your own pioneer, create opportunities. One of my colleagues that's on this call, she did family medicine and she was the first one. And that's another door that has opened, that we have hopefully opened for many of you. So emergency medicine, family medicine, and research is another one, as well as all of these other opportunities that we were never aware of. So please don't fall for the negativity. Create your own path and be your own person. Okay, thank you. That's me.
Thank you, Danelle. Very interesting path. Yeah, Danelle's just really done amazing work in the emergency medicine space, and she talks very highly about that part of her life. And that's so true. Like if you have an employer or a career path or something that you did that was amazing, there's no reason not to speak highly of it. And the most important thing, which I think Danelle does very, very well, is open doors for others. She's always the first one to recommend clinical associates in the emergency space, push clines in the emergency space, vouch for clines in the emergency space. So yes, she was the first to open the door and walk through the door, but she's also holding the door for other clines to walk through, which I think is pretty amazing. Okay, seems like there's not any questions in the chat. However, if you are interested in the TV space, as Tshego has spoken about, or that Aurum NGO space that Tshego's in, if you're interested in the COSUP space, if you're interested in the emergency medicine space, please let us know and we can put you in contact with one of these 3 speakers that we've had today that can point you in the right direction. I really hope that from today you've heard that it's actually not, it's not bad. Like we love our jobs and we love our jobs and we are blessed. Maybe we didn't pick it, but we in the space and we are flourishing in our spaces. So I think that's really, really, really important to know that it might not have been our first choices, but right now it's the best choice for all of us, and we love what we're doing. Okay, that's it from me. We 7 o'clock on the dot. I think it's time to go spend time with our families. Thank you, everybody, for joining us today. I know a lot of you are on holiday, students, but we thank you for coming on and spending time with us. And I really hope you've taken some nuggets of gold knowledge from our 3 speakers today. Okay, have a good evening, everybody. Thank you to Tshego, thank you to Dimakatso, and thank you to Denal for today. Thank you, everybody. Good night. This recording will be saved and will be uploaded.